you so much. And again, thank you for the opportunity to share with us my experience with research in the form of how to come up with a research proposal. On Monday, we went through the initial part, the introduction, what actually a research proposal is, and then the introduction, the background, the significance, and the actual bit which I enjoyed, which was how to write a literature review. And in summary, the literature review tells us the what, the why of the proposed study. The second part of this talk involves the methodology part, the methods aspect of the research. And it's important because it tells us the how. How will the proposed study be done? And are the appropriate measures or proposed methodologies appropriate and right for the proposed research? And that's what we'll be doing for the next an hour or so, if probably less. I fear there might be some technical, quote unquote, bits that maybe we met across when we are doing maybe our own research, if you've done research or the community health lectures. And I have to admit, it's not like I'm going to give the detail of this is how you do it, but more of giving the principles of why and how you are going to do the methodology section. And to digress a little bit, I remember, and why I always say, for me, the literature review, which tells me the why and what of the research is important. But even more important is the methodology, because once you agree, yes, you have a nice, wonderful study. If you give us the wrong methodologies, then the results you get will fail both the internal and external validity of your research. And I remember when I was younger in research, presenting one of my proposals for my MSc, and then the late Prof. Saidi comes and tells me, I'm happy with the why, the what, but you rushed through the methodology. And that's the most important. I needed to know whether you are going to achieve the things that you proposed to do. And for the objectives, you're going to meet 4 objectives. We'll describe the structure of the method section. We'll describe sample size calculation, but I add this a little bit so that we just get the principles. It's difficult to get how to calculate a sample size unless you are on the ground, you have a proposal, and you need to calculate that sample size. That's when the rubber meets the road. Then number 2, we'll describe how to create data collection tools. And again, not the how so much, but the principles behind data collection tools. And then we'll finish by discussing bias and confounding factors that might crop in when you are doing the study. So now we start with trying to see how to. Okay, yeah, that's better. So what is the structure of the methods section? And I need first to tell us that the structure of the research of the method section usually is predetermined by the institution where you are submitting your research. For example, University of Nairobi has a prescribed way in which your methodology section would be. So it's like you're making sure they are following that. Even for funded research, then the funder will give you a template and then you will just be filling that. And therefore, you don't need to cram anything, but we are just going to talk about the parts that must be found there. And the first one would be to tell us the study design. Is the proposed design can either be qualitative, quantitative, or a mixed methods research. And it's important to give us that opening statement why that study will be, whether it's experimental or observational, because from whatever you are proposing in the literature review, you pointed us to a certain direction that made us expect the type of a study design you are going to use. And therefore, we'll be expecting that you are choosing the right study design. And you have to defend your reason. That's the rationale. Tell us why you chose the particular study design. How does it fit into your getting the objectives met or answered? Then you tell us the study setting. Where are you going to do the study? If it's KNH, a clinic, for example, the rheumatology clinic or the endocrinology clinic, the setting tells us whether you'll be able to achieve the sample size in the given period. For example, if you propose a study that is going to occur in 3 months and the sample size is 1,000, then you also need to tell us that this clinic sees 100 patients per week. And therefore, if we extrapolate, the time you've chosen will be enough. That's the context, the setting. If you tell us you are going to do it in Nairobi, and that's Aga Khan, for example, KNH, Bagathi, and Nairobi Hospital, you're telling us I'm choosing these 4 study centers because one, some are more affluent than others, while others see patients of a lower socioeconomic status, for instance. And therefore, you want that mix so that your results or the sample size will be representative of the patients you are going to report about. So we need a little bit more detail than just saying the study will be done in Kenyatta, the study will be done at Mbagani. You need to tell us the why of the choice, what informed the choice of that study location. Then the other bit would be the participants. And usually you are telling us the target population, patients with HIV/AIDS or children below 5 years old. And then you tell us the inclusion criteria, who qualifies. Patients who meet the diagnostic criteria for pulmonary embolism as defined by 1, 2, and 3. Then you say, I will exclude these patients who have maybe another clotting disease, sickle cell, and the like, and you tell us why you are excluding them. Then you also have to tell us how you are going to sample these patients, sampling method, and why you chose that particular sampling method, as we shall see later. Then now you tell us how you determine the sample size for the patients who meet the particular criteria. These parts, some people might mix them, but routinely that 3 components about the participants must be there. Then you tell us the materials or instruments you are going to use. If you're going to use a weighing scale to measure the weights of your patients, then you need to tell us, I'm going to use this brand of a weighing scale, which has an accuracy of X, 0.1 per kilo or per watt, and I'm using it because of 1, 2, and 3. Some study requires you to even tell us the batch number of the particular equipment. And you might be asking why. Because of reproducibility of your result. The results should be able, somebody should be able to pick your protocol and go to Cuba, replicate that study, and we get the results. If you are using a software, you need to tell us which software you are going to use. For example, if you are going to use an online calculator that gives you the score for acute appendicitis, for example, you need to tell us this calculator was online, this is the URL or the website that you can get it, and why. Is it approved by a certain body or not? Then these instruments or tools you are using, have they been validated? Are they reliable? If they are existing, usually not a big deal. If you are using a weighing scale or DP machine, then we've been using it, so people have been using it, and therefore maybe the reliability and dependability of that tool is there. But if you are using new instruments, then they need to be validated, especially for those who are developing a new tool to do something, to measure something. Then you need to tell us that this has been validated via 1, 2, 3 measures. You also need to tell us the procedure, how you are going to measure the BP of these patients. That this patient will be invited in a cool room, quiet. They'll wait and relax for 5 minutes. They'll be explain the procedure, and we will tell them to lift their hand, place it on a table, put the cuff, and tell them to keep quiet, and we measure this blood pressure. Twice or thrice, you get the average. So what we are saying is we need the step-by-step description of how a particular result will be gotten. You also need to tell us how the data will be collected. And if there are standard procedures, have they been replicated? Who collects the data is important. Will they be trained on data collection? And what will be the quality assurance measures that will be applied to this process so that we all do the right thing? And then we usually complete that by doing the data analysis. And the data analysis should mirror, one, the type of data you've collected, and number two, the objectives. If you are comparing two groups, then you will tell us a t-test will be done. If it was just a descriptive study, then you will tell us the frequencies, the proportions, the mean, the median, the mode. If you are going to do regression analysis, then we need to see the appropriate test being applied. And usually I like this area organized in reference to the references that have been, the specific objectives that have been proposed. Then usually the last part of the methods is the ethical considerations, but the most important. And you are telling us, these patients you are going to recruit into the study, will they give you an informed consent? How will it be obtained? For special groups, people who can't read, people who are too sick to participate, who will give consent on their behalf? How will you maintain confidentiality so that we don't know patient A is Guti and patient B is Kulud? How will we be made anonymous? And therefore those measures, whether you are going to use numbers or not, or specific key to reference a particular patient, and then how you will lock if it's hard copy data, where will it be kept under lock and key maybe? If it's soft copy data, who will have the password to make sure that data is not accessible? Then you need to apply for ethical approval via a review board. Usually a very important step because it's the one that checks in whether the study is worth doing, has been done elsewhere, and therefore we may not have justified why we need to repeat it, whether the measures taken, the post methodologies are safe, are the right ones, and therefore we can go ahead to do the study. Then if you get the ethical approval, you also need to tell us how you will get institutional and legal approvals. In Kenya, for instance, you need the NACOSTI license. If you are doing it in the county hospitals, you need the counties to approve. You even need the management of that particular facility to approve. You also need every license that is needed so that you are free to go with your data. If it's a document for examination purposes, then the mother department also needs to approve and say, we are satisfied with this student to go and collect data. And there should be evidence of all those measures. Then at the tail end, the methodology tells us the timelines, how and when each step of the study will be done, and the resources you've allocated for that, so that we ensure now this study can be done. There's usually a section that tells us the study limitations. What are the hiccups, the shortfalls of this study, the things that you may be outside your ability to control? And then how will you remedy for that? For example, if you are including patients who are too sick to be recruited, but they were eligible, then you might need to exclude that. Then you tell us you'll continue recruiting until the sample size is achieved. Then there is the delimitations. Usually, I've found many students think study delimitations is the opposite of study limitations. No. Delimitations are the confines through where you decide I will collect my data. For example, if you are calculating the prevalence or the causes of esophageal CA among a certain group of people, then you might say, I will look for the risk factors about age, use of smoking, eating certain foods, and the like. Then you say, but my research will not look at the genetics of these patients. So I'll not be determining the genetic susceptibility. So you've delimited, you've said, I'm ring fencing my study to be within these boundaries, and I'm not including this because they're outside the scope. Maybe they're too expensive, or the technology, you do not have it. Now, that was the bit about the structure. Let's go to the second objective, which was the sample size calculation. Sample size calculation. And what is this sample size? Sample size is usually a representative subset of the population. If I need to know the age of my first years, I can go to each and every first year and ask them their age. Or I can just decide to pick every second row of my students. Out of the 400 students I have, then I might have 20, 30 students. Those 30 students I'm going to collect data about and project that result as if it's going to the entire population is my sample. And routinely, you can do it manually. You can sit down with your calculator and type, you get it. Or you can use available softwares, and we shall see soon when you can use that. And there are many of them. Either online calculators or statistical software packages. That's not the problem. That's not the gist of the matter. The most important bit is to know why you are using a particular method to get the sample size. The meat of the matter is when you know which formula, for instance, what factors to consider. Because you can easily key in things that you do not understand, but it's always good to be able to understand. And that will be the bigger portion of this presentation. Good. Now, what are the expectations of a sample size? Number one, it can actually be a small sample size. And when is it okay to have a small sample size? If you're dealing with rare diseases, then you may not have the luxury of having enough people to recruit. If you are doing it in high-risk population, for example, drug abuse among medical students, and maybe they are doing things beyond, or you are going to research your data among serial killers, and serial killer may not be the best, but things that you feel these are high-risk groups, then you definitely not get a big sample size. However, we need to realize this. If it's insufficiently small, then it becomes difficult to reproduce those results. And the other thing is may give you high false positives. For example, if you think people who are hardcore criminals lacked father figures, then if you go and get 10 guys and you find 8 of them do not have fathers, then you might think all hardcore criminals do not have father figures in their lives. And that's what we are calling the high false positives. And therefore, the consequence of that is it undermines the scientific impact of the research. You cannot really generalize these results to the general population. You can also have a too large a sample size, which it's possible because if you are doing the age of first years, you can all go and get all the first years you have there. But now it comes about the issues of ethics. And even before we go to the phase 1 studies where you are doing experimental research on human beings, usually the big question is, why are you wasting time? Why are you wasting resources? If you had calculated a sample size that gave you 250, the 251 patient that you are collecting data from is actually unnecessary. So issues of ethics. But again, as we're seeing here, high false positives, then you can also have p-values there because you are going to collect, and we had said 95% confidence level, a p-value of 0.005 will be taken as significant. Then the more you collect, it's like we are going towards the population size, and therefore you might give us data that may be a little bit misleading. And what you are saying is you need a balance between the right, not too many, not too few, and that's what brings about sample size calculation. So what is needed when you want to calculate sample size? This cartoon here has words that I want us to familiarize ourselves with, not now, or if now, better for those who have been exposed to this. But I want you to understand and have this because these are some of the things we look at when we are reviewing the methodology of patients. And the first one, you need to provide information regarding the statistical analysis to be done. I'm going to I'm going to do a descriptive study. So I'm just going to report the mean, standard deviation. I'm going to talk about median, the mode, the frequencies. But if I am going to compare two groups, I'm going to do regression analysis, then that information needs to be there because now we start talking about the power of this study, how we are going to power this study so that we get the right sample size. We also now start talking about confidence level. I want to be 95% confidence that the mean I get is 95% within this, 95% of the times it's going to be found here. And those are the things that we need to talk about. You need to determine the precision. Precision usually is how sure you are that the sample mean and the population mean, how close are they? How precise? How close would this be? That's our precision. And the study power is you want to power it high enough so that you can be able to say if the alternative hypothesis is true, then you can also say no about it. The confidence level, that is what we are talking about. Confidence level and precision levels tend to go hand in hand. And you want to say the results you get, you'll be a certain percentage sure that it's not by chance. And then you talk about the magnitude, the effect size, and we shall see it as we go about. Now, what are the factors that influence determining sample size? What are the factors? What are the factors? And the first one that you will meet is the sampling design. Sampling design. I'll give us a scenario of medical students. We have level 1 to level 6. And I need to determine the ethnic composition of my medical students. I might decide to randomly go and ask people around first year, second year, third year, fifth year, sixth year, without determining whoever it is. But if I am in Chiroma, I'm likely to meet very many first years and almost an equal number of second years. The senior classes are in Kenyatta, and therefore I might miss that data. That's the bad thing of simple random sampling, because you do not give us a sampling criteria, sampling frame. And therefore, if I had a sample size of 300 out of the 1500 plus students I have, then the moment I hit 300, I get moving. But that sample is not representative. But if I want to represent a representative sample, then now I need the multi-stage sampling procedure, where I might decide to cluster my patients, my students. For example, I say I have first years, they are 400. I have second years, they are 350. I have fourth years, they are 200. Final year students are 150. Therefore, for my sample size, total sample size is 300. This percentage I'll allocate to first years. The next percentage I'll allocate to second years, and the way and that, which means I might be forced to consider that clustering or stratification when I am calculating my sample size. And that also comes to the non-sampling study design. For example, when you are assigning people quarters, you need to know which quarter. If it has 5 patients, then you need to know, I need to get one out of there. If another quarter has 50 patients, then you might need to say I'd get 8 patients from there. The second factor that you need to consider is the statistical analysis plan, as I had hinted before. Are you doing descriptive statistics? Then not much to worry about. But the moment you start comparing groups, that's inferential statistics, then power analysis becomes very important. Power analysis becomes very important. And that's why we now determine the sample size. And the sample size will equally be determined by the level of significance. If I say I want to be 95% sure, then my p-value becomes 0.05. But if I want to be 97.5%, then I take it to 0.01, vis-a-vis going to 99% and the like. We also need the size of the population standard deviation, and the standard deviation is usually taken from previous studies. So if a previous study reported a wide standard deviation, then tells you the particular parameter you are looking for is haphazardly widely distributed. You might find an age of 5, another age of 70. Therefore, that gives you a very wide standard deviation. But if it's narrow, it means whatever you are looking for is concentrated at a particular lot and therefore becomes easy. Again, the magnitude of the means of difference. If you want a bigger magnitude, then you may not really need a big sample size. But if you are looking at a small difference in pressure between group A and group B, then again, sample size has to become big. Another factor to look at, and again, as I had said, you remember I told you there are some terms that you will meet around, and I want you to familiarize yourself with, is the level of precision. And precision is usually, you have the sample and you have the population. The sample is a small group out of the population that you are going to calculate. Now, if you want the mean, for example, of that sample to be as near as possible to the population mean, that is a parameter vis-a-vis the statistic, then you want that precision to be very, very accurate. You have a very high precision. And precision just tells us how close you want your calculated parameter, statistic, that is calculated value from the mean, from the sample, to be as near as whatever was found in the population. And this range of accuracy of estimating the true value of the parameter is what we call precision. And a higher precision means, a greater precision means a smaller sample size and vice versa. A small sample size will give you a very big off precision mark. And then if you increase the sample size, the precision becomes smaller. Level of confidence, again, as I've said earlier, is how confident, how sure do you want to be that your result will lie within a particular margin. When we say 95% confidence level, then you are saying, I'm sure whatever I'm going to calculate will be within this 95%, and only 5% will be chance. If you increase that to 95, to 97 or 99, then you are saying you only allow 1% chance that these results will be by chance, 1%. If you lower it to 90, then you are saying 10% of my results will be guesswork, quote unquote, but 90% I am sure. And usually this will leave it, especially for clinical trials, things that you don't want to guess around, then you take it a higher confidence level. For the descriptive studies that you are not going to harm anyone by saying the weight of first years is 95 kilos, then you are okay to say 95% of sure. And the degree of variability, for example, if you are comparing two groups of patients and you are saying their mortality, and then you say the younger ones are likely to survive chemotherapy vis-a-vis the old ones, then you might need to tell us how different will they be. If the difference in age is higher among these patients you are looking at, then the mean will also be very, very, have a big standard deviation, for example. And to account for that, then that degree of variability is important, because not everything in your sample size will be uniformly distributed. And usually for many studies, the degree of variability given as P, we usually take P minus 1 minus something. And that usually take, if you do not know the variability, then 50% is the starting point. But you can increase that. You can increase that and continue until you are sure about it. And the last thing that influences the sample size is the non-response rate. Non-response rate. Why? I'm sure most of you have been sent a link. Somebody has created a link, they are doing their research, and they just want you to answer those questions. And enough of us never, ever replied to those links. You are part of the non-response rate. For those who answer those links, thank you. As a researcher, I say thank you. For those who don't answer, then the researcher is forced to account for them. And how do you account for them? You calculate your sample size and find I need to contact 100 doctors. Then you say 20% may not reply, and therefore I'll collect 120% of my calculated sample size. So you'll say my sample size here is 120. Now, if they answer 119, you have 19 more. But if they answer 99, it means you would have easily gotten 80 It's just that these 20 that you had added took care of your level. So what are the strategies now? We've talked about the factors. Now, how do you go about the practical bit? How do you determine the sample size? Usually, some of the things, the steps you might need to do, and especially if you are the pioneer in doing that research. But remember, on Monday, we said we don't do research in a vacuum. There is usually somebody who has done it. But if, for example, we are to get a very rare disease or a very new disease that is afflicting us, and we need to calculate a sample, then we might need to go and do a census of a small population. First, go and get that village, put them there and count and see. In this village, the new 20% of the total villages are having new skin eruptions. And then now you can use that 20% to go and calculate a sample size that will be bigger for that. Or you can just duplicate a similar study, which was well constructed, well designed, and then you use a sample size similar to whatever they used. Or you can just go to the internet, just type online internet sample size calculator. There are so many. There are so many. The beautiful thing is you will still be required to know the power, the precision, the degree of variability. And that's why I took time to try and emphasize to us that we need to understand that. Once you key in that, then you will get your sample size. But always give us the link where you keyed in those sample size. Then you can use published tables. These are usually found, especially in qualitative studies, they have a lot of this, and they publish them, and you just put in the figures that you have, and then you get your sample size. But again, I insist, you need to know the why you are using a precision of 90%, why you are using a power of 70%, what is standard deviation and why you are using it, and what would be a wide standard deviation mean to your sample size. Then the most common ones that we tend to use are mathematical formulas, and you can see some of them here. There are many. For prevalence studies, there are mathematical formulas for that. For comparing means of two different groups, they are there. For calculating proportions, they are there. And it's beyond the scope of my talk to go into those details. But I paused and said, when possible, determine this guy we are calling the effect size. And especially when you are comparing two groups or more than two groups, look for that effect size. And you are saying, what is it? It's a minimum effect on intervention that must have in order to calculate the appropriate sample size. For example, if somebody in Nigeria said the difference between 6th years and 5th years in height is 2 centimeters, then you need to have that effect size of 2 centimeters. If another one said is 10 centimeters, then you are looking at a past study that told you that difference is actually as big as 10 centimeters. And when do we use that? Whenever you are looking at an intervention exposure. That means you are going to give paracetamol to this group, ibuprofen to this group, and then you are going to say the temperature will drop by 0.2 degrees Celsius. That one you need to know. You need to quantify that because it will tell us the difference and give us the more. And remember, if it's a small effect, if it's a very small effect, then you really need a large sample size. But if it's a great effect, then the sample size becomes small. And how do you arrive at it? you have experience, especially a nurse who has been giving paracetamol and another one has been given ibuprofen, and they are arguing which one is better, then one might say, let's use 2.2 degrees Celsius to say that will be the cutoff. Another one will say, okay, let's use 5.5, and that is the thing that we are talking about. The other thing would be, as I said, the example of somebody reported the difference between 50 years and 60 years is 2 centimeters, another one said is 10 centimeters, then that difference, that 2 or 10 is what you will use, estimated from where previously implemented well-designed studies. The other thing, if you want, especially to look at the effect size, to just do a pilot study. Your patient, you give every second patient you give paracetamol, every third patient you give ibuprofen. Then you see which ones, this one should cut by 0.2, this one should cut by 0.5, and then you say, now let's go and design a study to prove whether this is true. Now, there are some 2 or 3 slides that are coming up that will tell us some practical steps whenever we are designing, whether we are calculating sample sizes. And the first one is especially for descriptive studies. And the first, if you are just doing descriptive studies, the means of everything, then the confidence level becomes important. 95% confidence level will mean the p-value is 0.05. Once you determine that, then if it's the mean you are looking at, then say the standard deviation. That's the standard deviation you will use of a previous study to calculate your sample size. If it's the proportion, then now you need to use proportions of a previous study that said 30% of patients with diabetes will also have hypertension. That is what you will use. If you are using calculating sample size for comparing 2 groups, then again, power becomes very, very important, even though it is not always to match the 2 groups, because we need you to calculate. And what I need you to remember here is the sample size you'll calculate here almost always is for one group. So if you get a sample size of 40, it means group 1 will be 40 and group 2 will be matched to 40, even though the matching may not always be possible. Then the other bit that will come about, remember we've said here you might need now to put groups, then you might need to do your probability sampling. And I will not emphasize much about this, but there are measures that we take and shall see later. When you want to reduce bias, then sampling becomes very, very important, whether it's probability, which is simple, systematic, or stratified. And its wonderful advantage is that you will have higher generalizability of the results, a greater representativeness of the population, and a lower response bias. And why? Because everybody has a predetermined chance of being recruited into the study. Unlike non-probability sampling, and most of us, especially when we are doing studies for us projects in school, we tend to throw the word, I will use convenience sampling. And I always quarrel with people about convenience sampling because you are just saying every patient who walks into that clinic, I will recruit. But what if that clinic says Thursdays is for high-risk patients and Mondays is for low-risk patients? Then you will find yourself giving us data for Thursday, if that is when you are free and you are using convenience sampling, and you'll give us results that are not true or do not reflect the general role in the society. That's the danger of non-probability sampling, including convenience, quota, and those others like snowballing. And that's why you need now to bring about now the sample size, because you need to include as many subjects as possible. And unfortunately, it's prone to selection bias because you just need your friends to come in and you'll recruit those. And the more difficult guys who you do not talk to, maybe you will not recruit. If you are using for regression or correlation analysis, then remember, especially for regression or correlation analysis, remember when you are doing that, the most important is the number of observations. I wish I had put this in bold. So those people will come and tell us, I will try to see how age, gender, and family background influences the occurrence of diabetes or a mental health disorder. Then remember, the more variables you are going to subject to the analysis, the greater the sample size, Otherwise, those results, if you use a small sample size, then it's difficult to generalize those results, and will give us large confidence intervals. And large confidence intervals gives us a misleading report. Nevertheless, what are the general recommendations when coming up with a sample size? Account for non-responsive rates. Every time you calculate a sample size, add 10%, 20% of patients who might not return the feedback, of doctors, nurses, pharmacists who might just see the link and continue scrolling down. Usually we put it at around 10%. If you find yourself going higher than that, then you need to justify to us why you feel that group does not give you the responses. Avoid unrealistically large samples. And that's why I put what would be the additional value of that extra patient you are recruiting. That extra response you are recruiting usually doesn't add any value. You just waste resources, time, money, and the like. So how do you come up with data collection tools? This is a short one, and I just wanted us to acknowledge this, that the type of data collection tool you are going to use depends on the type of data you are going to collect. And therefore, I feel it's beyond the scope of this to go through each and every data collection tool you are going to use. Therefore, I'll just give principles. Remember, it's either quantitative or qualitative. And quantitative can be observational or experimental. So how you are going to come up with those tables for quantitative data is key. For qualitative data, how you are going to interview those groups, how you are going to do all that is important. And this table gives us the different methods that you need to use, when to use it, and how to use it. Just the principles. Primary data or secondary data is another consideration when you are coming up with the tool to use. And primary data might be surveys or questionnaires, interviews, observations, clinical trials, interactive response technology, where you put up a software that is able to guide somebody through. And those are tools that you use for primary data collection. Or you can use secondary data collection tools where you go to the patient's records or public databases or even literature reviews. You go and review the literature and come up with a meta-analysis or a nice narrative review about a certain topic. Nevertheless, especially for quantitative data, then there are many online tools, and we agreed because of technology, we have that advantage. Please, I will not go through all of them, but all available. You just need to Google and you will see. The most important thing to remember is you need to customize that tool to your needs. Customize, I repeat, customize your tool to this kind of study you are collecting. Nevertheless, you might come up with errors when you are collecting data. And what are the sources of error when you collect data? Number one, and these are the things that, especially for us, when we review protocols or when we are reviewing submitted articles, these are some of the things that we look at so that we are sure what you are reporting is authentic, it's right, it's methodologically correct. And the first source of error is when you talk about the population-specific error. If you don't define for us who your target population is, then you might easily collect data from anyone, and that introduces error. If you are saying, I'm going to collect data for patients above 18, then you go to Kenyatta and find anyone above 12 is sent to the adult clinic. Then that becomes something that you need to define. Or you are a pediatrician and you feel, I need to collect data of children. In private hospitals, these children sometimes go to 21. Then if you don't tell us that data was collected below age X, then it becomes a source of error. Another thing would be the sampling frame. And sampling frame is you're saying every third patient or every 15th patient, if that frame you've defined does not capture a representative sample, then you might give us a sampling frame error. A non-response error is if I was to send data about to students or to the general population, and a certain group of people feel, you are targeting us, and said, for example, if I was to do a study about the general view about same-sex marriages, and I send it to the general population, and the heterosexuals feel like this is not our thing, and they decide not to respond, and then the same-sex guys respond, then I have a non-response error because there's a group that felt, this is not our thing. You might select the wrong people, gives us selection error, and especially when you use non-selection random sampling techniques. If you measure your things wrongly, especially like using hypertension, if a patient comes and without resting for 5 minutes, they come before you even sit down, you are clamping their hands and sending them to away, the pressure you get there is slightly elevated. And that's why I would want to caution, especially for the MED guys, if you are going to collect data from the clinic, please, the blood pressure recorded in that file is not usually the right one. You might need to collect that blood pressure on your own. What are the best practices when collecting data? Number one, clearly define the objective. Clearly define the objectives. If the objectives are clear, we just want to see which methods are being used and how are they applied. Please tell us within which time frame you are going to collect your data, and if possible, adhere to those plans. Why? Because if you are graduating in 6 months' time, please, in 3 months' time, finish your data collection so that you have time to write your results. If you are graduating in 6 months and you propose for us a data collection schedule that takes 12 months, then you will definitely delay your graduation. Choose the right method. That one doesn't need a lot of explanation. When unsure or when not very clear, try to do a pilot test and see whether you'll be able to achieve the numbers that you've proposed for us. For those people who use helpers, train them and train them correctly. But most important is their baseline qualifications. Their baseline qualifications. You not pick just anyone to come and measure, for example, BP, especially if we are using the standard method of the one with mercury. follow the standards. Follow what you put in that protocol. Please follow it to the end. If possible, and we shall see how to minimize bias, minimize it. Maintain data quality, data confidentiality, and at every given time, document. Those things you tell patients they will sign informed consent. Please give them to sign. Give them to sign. Now, we talked about bias. Now, how do we minimize bias? But we first need to know what is it? And the most important thing is it's systematic. It's a systematic mistake, which means you are not just deciding for this one, let me not do it. No. Most of the times, bias, you find it doing it. You just find yourself doing it. And most of the times, without even knowing that you are going to do. For example, because bias can happen at any stage of the data, of the research process, you can easily have bias with the result, with the papers you are quoting. If you decide, oh, if there is a paywall, that paper I'm not going to look at it, then you already introduce a bias when coming up with the protocol. If you decide all papers in Spanish, I'm not going to look at them, already that is bias, because any guys who reported the prevalence of a particular disease in a country of a similar economic environment like Kenya, but because it was written in Spanish, you said, let it be away. You've already given us bias. And that's why we are saying it's a systematic mistake. Either in the planning, execution, or analysis of a study, resulting in inaccurate conclusions. The study might be right, the results might even be very genuine, but because you collected them, for example, in Kibera, then you cannot say the rates of diabetes in Kibera in Kenya is lower because Kibera has a certain percentage of a certain socioeconomic status. And therefore, usually influences or affects the dependability and accuracy of results. What causes it? Usually subconscious bias. As I've been telling you, you've just decided to go ahead and quote papers that are in a certain journal. And because you've been told they are predatory journals, then you decided any paper published in Nigeria, for example, I'm not going to publish it. It becomes subconscious. Influence of funding sources, and especially if you've been told, write a study on the prevalence of drug abuse among homosexuals, for example. Then because the funder is usually maybe supporting that cohort of people, then you decide to quote papers that decided to quote a higher prevalence so that you tell us the burden is really, really high and we need to intervene for this group so that they don't. And also be in the design and execution of the study or use of non-random sampling methods. And that's when I brought about the convenient sampling or inadequate blinding methods. And there are different types. I will not go through each and every one of them, but they are there. And what I want you to remember is they can occur at any given time, either when trial planning, when you are writing the study, what we call the pretrial bias, or during the study or after the study. And after the study is usually citation bias, which one I want to emphasize citation bias. When you decide to tell to just quote studies that reported similar findings to your own, then you paint a picture that, hey, your study is just aligning with these studies. And that gives us a citation bias. Or you decide to publish in a particular journal. so that you don't publish in others. And this journal might be a high impact factor journal. You pay all that money and you give us that information. There are many different types of biases. That's what I'm trying to say. How do you avoid it? Especially when you are doing the study. At the point of doing it, then use random sampling or try the stratified sampling where you go at different levels. Avoid, and that's what I'm talking about, avoid convenience sampling at all costs. If you may, avoid convenience sampling. And you might easily say just every patient, every fourth patient I'll be recruiting. So the first 3 patients who come, those ones are not. Then every fourth patient, and because patients just come in, then you have that. For qualitative studies, then you might need to employ open-ended questions or follow up with non-responders, especially when you send out your link to a group of people. There are 100 people in that WhatsApp group, and 40 have answered. These 60 that have not answered, you might send them reminders individually to try and get them to answer. General measures, proper study design. This is very important. Peer review and oversight. And that's why we always insist all studies must go through an ethical review process. Because these are the guys who will remind you, hey, why have you not done 1, 2, and 3? What are you going to do about 4, 5, and 6? Be transparent. When you meet results that do not seem to be true, please don't hide those ones. Report them because they are part of that. Triangulation means you are going at different levels. Either you are using different methods to get the same, or you are using different people to measure the same thing so that you measure that. For quantitative research, then you might need to randomize or blind the study participants, follow the standard procedures, and this thing called intention to treat analysis. If you are doing a random controlled study, then if 10 patients dropped out of the 50 you are following up, include the results of these 10 who dropped out and see whether they affect any outcome. How do you measure of redeem in qualitative research? Then reflexivity is important, where if you feel your own opinions are clouding you, catch yourself, especially, for example, if you think others should not be around, then ask yourself, is my personal belief, or if you are the one who feels God doesn't exist and you are doing a study about faith and mental health, then make sure your beliefs do not affect your view. Purposeful sampling, if you know the people who are passing are most likely from a certain group of school and you want to know how they study, then you might target that instead of just going to everybody. Response validation, if somebody tells you an answer, then you might need to ask them to clarify so that you know whether that is what they mean. Ask probing and neutral questions, and then ask until no more themes seem to be happening. And the last part is the confounding factors. And what is a confounding factor? A measure of an unmeasured variable, and the emphasis of it is unmeasured. Usually you're not even going to target it, but it influences both the supposed cause and effect. Supposed cause and effect. For example, if I want to look at esophageal cancer among the Kalenjins, for example, and I'm looking at throat cancer and Mursik, or throat cancer and people in Highland and very hot tea, then there are factors in between that I'm not very much interested in that might be confounding. But there are factors that I'm interested in that are part of it. So if we stick to our throat cancer, that is the effect, then I have advancing age, I have smoking, and I have the intake of hot tea, and I have the ETEC of MORSIC as variables that might cause throat cancer. But there's a guy here called genetics that have no capability to measure. Then genetics of these patients becomes a confounding factor. And therefore, confounding factor must satisfy these three criteria. Must have an association with the disease. That is a risk factor. And therefore, in this example I've given you, genetics is a risk factor to throat cancer. Must be associated with the exposure. If a genetically susceptible person is exposed to hot tea or MORSIC or cigarette smoking, maybe he will get throat cancer. Must not have an effect on the exposure. Your genetics do not influence you to take MORSIC, to smoke, or to take very hot tea. It's just a behavioral thing. And those are what we call confounding factors that we need to always bear in mind and discuss, especially when discussing our results. We need to bear in mind the influence of confounding factors. How do you prevent or control for them? Randomize restriction, which means there's a group of people, if they are high risk people, then you might need to take them out. You might need to match people with a predisposed condition to those without a predisposed condition and see. Or you stratify, whereby you go at different levels when analyzing your results. In summary, sorry, I feel I've talked for long. What have we done? We've described the structure of the method section. We've described principles of sample size calculation. We've described considerations on how to create data collection tools. And we've briefly gone through bias and confounding factors. Thank you so much for your time.